I I don't know. Many years ago, I came to Guwahati. I
Okay,
forgot.
okay. So I was not there, but there are
Nayan,
many.
Nayan,
Yeah,
Nayan Dekar, some
yeah. Nan the
posted.
guy. So he's one of the allergy practitioners in Guwahati.
Yes.
He's our junior. There are
Sir, we
many.
are live now. We will be starting.
Right, right.
Huh. So shall I go ahead and share?
Sir, just wait for a minute.
Acha.
Good evening, everyone. Namaste and a very warm welcome to all participants joining us from across India and around the world. It gives me immense pleasure to inaugurate this landmark webinar series on allergen immunotherapy titled Foundations to Frontiers, organized by IAP Allergy and Applied Immunology chapter. As we gather here today, we stand at a critical juncture in allergy care. The burden of allergic diseases, rhinitis, asthma, atopic dermatitis, and food allergy is increasing rapidly in our population. Yet, awareness about disease modifying treatments like allergen immunotherapy remains limited. With this initiative, our aim is simple but profound: to demystify allergen immunotherapy, empower clinicians, and strengthen evidence based allergy practice across the country. This is more than just a series of webinars. It is a movement to bring allergen immunotherapy into mainstream pediatric and general practice with clarity and confidence. Over the next few sessions, we will walk through the science, selection, safety, and future of immunotherapy with some of the finest minds guiding us. I am especially honored to open today's session with Dr. P.K. Vedantam, an international thought leader and mentor to many of us, whose decades long service has laid a strong foundation for structured allergy care in India. And it is only because of him that we are here today and whatever we are doing. We are equally delighted to have Dr. Taha Ashraf Qureshi and Dr. Spurti Chitta, both representing the dynamic emerging generations of AIT expert. I am very happy to invite Dr. Mrityunjay Pau, a very strong voice from Northeast in pediatric care, to moderate today's session. Dr. Pau is trained allergist with special interest in taking care of sick children. I sincerely thank our allergy chapter team who work tirelessly behind the scenes. My heartfelt gratitude also goes to each one of you for being part of this journey. Let us begin today's session with open minds and the shared goals of transforming allergy care, one patient, one clinician, one site at a time. Thank you. Now I would like to invite Dr. Mrityunjay Pau sir to moderate the session. Dr. Pau sir.
Thank you, Dr. Neeraj. It's a big opportunity for me. I will introduce our speakers one by one. First of all, our first speaker is Dr. P.K. Vedantam, who is a globally and world-renowned allergist and founder of the International Asthma Services, which is based in Colorado, which is a charitable organization. This was founded with the aim of spreading the knowledge of asthma and allergy in children in developing countries. He currently serves as the clinical professor of medicine at the University of Colorado, Denver, and he is the recipient of several prestigious awards, especially including the American Academy of Asthma, Allergy, and Applied Immunology, and the AAPI Distinguished Physician Award. He will be starting this very important immunology series with his opening session titled "From Genre to Precision: The Evolution of Allergen Immunotherapy." We welcome you, sir. Dr. Vedan, sir, please. So, sir will be
Thank you.
speaking
Thank
for
you
the
very
next
much.
25
Thank you.
minutes. Yeah. Thank you, sir.
Thank you, Dr. Mrityunjay. And can I go ahead and share?
Yes, please do, sir.
And I appreciate the IAP leadership as well as this incredible energetic group led by Dr. Neeraj Gupta in making these things possible. I could not imagine so much of interest being shown in the field of allergy a few years ago. Now, we used to have, in the past, I remember we used to have these CMEs once in 3 months, once in 4 months. Now it is once in 3 days or maybe less. Almost every week there is something going on. And this is a incredibly welcome change in the propagation of the knowledge of allergy across India and beyond. And Dr. Neeraj approached me. He told me, can you talk about allergy immunotherapy, the history behind it? I never done it before. I have talked about the mechanisms and the indications, contraindications, that type of stuff. So this particular talk is about the story behind what we are doing. This is the story behind. Many of us may not even have paid attention who were involved, what was involved behind the type of modality that we are using every day. So this, I hope, will open up your mind to appreciate the efforts, the pain, the suffering, dedication, and a lot of hard work of our senior physicians who may not be anymore here living, but their memory is living. So I'm going to start off with saying AIT history, allergy and immunotherapy history. And let me go ahead and can you hear what I'm saying?
Yes, sir.
Is, is it okay?
It's
So
clear.
what I'm going to cover in this talk are where did we start and where are we standing now? Where did we start with this immunotherapy and where are we now? A lot of information was obtained from Dr. Nelson's incredible article in the Annals of Allergy, where he had said the evolution of immunotherapy. In this is a volume 126 in 2021. As we all know, this disease is a very old disease. It goes back to the age of the pharaohs, Egyptian pharaohs, Menes, who was stung by an insect and he instantly died of anaphylaxis. And the ministers who were in that court were very bright people. And they recognized that something external has caused the problem. He is a very, very able, young, able bodied, healthy person who just died suddenly due to something occurring from outside. And that means there is something external that caused the reaction. And what is that thing that might have provoked that severe reaction? And that was not discovered for several centuries until 1968, which is only 58 years ago, 57 years ago, the discovery of IgE. So that Egyptian pharaoh Menes had specific IgE against whatever insect, whether it is a bee or honeybee, a wasp or yellow jacket, and that what causes his anaphylactic reaction. So, since the discovery of IgE, we have a huge number of scientific studies galore because for the first time in the history, the specialty of allergy or the field of allergy got married to immunology. Until then, we did not know, people did not know what is this reaction occurring. We know the reaction occurring, but what is the mechanism? That was not known. So we need to go back way before IgE and look at what was happening. So, if you look at the history of allergy and immunotherapy, it actually parallels the history of allergic rhinitis, what we call nowadays allergic rhinitis. It was called something different then. 2000 years, 200 years ago, there was an effort by Dr. Bostock in UK who started looking at this very strange phenomena. At that time, physicians were all very highly placed, and their patients or their accomplices are all highly placed people, but they also took care of the common man also. And what Dr. Bostock in 1819 observed was there is some sort of a catarrh or a cold which makes people sick. They don't feel good. They have nasal symptoms, eye symptoms, they are tired, they are moody, and that seems to occur during certain seasons like summertime. And he called it summer catarrh. And he was blaming it on sun rays, heat, and also a very, very important thing. He thought, oh, yeah, it could be the smell of the fresh cut hay. What is hay? Hay is nothing but grass that you see all over. It grows very easily, it germinates within a week, and it is used primarily for animal feeds, horses, cattle, sheep. And then there was a huge amount of vegetation all over with hay growing to feed these animals. And when they cut this hay, and there was a smell coming, and he blamed the smell on it. And that is why the term hay fever came. Hay fever was nothing but the seasonal allergic rhinitis, which was initially called summer catarrh in early 1800s by Dr. Bostock, a British physician, a total intelligent observation. And Dr. Blakely is the one. Let me show you what is Blakely. Blakely is the one who actually started doing pollen counts and pointed out that grass has the culprit antigen. I got a little bit more interested in Charles Blakely because he is the one who is actually quoted a lot in the allergy literature as if as the father of allergy. He was actually was born in Lancashire and belonged to a very ordinary family. His father died early, so he moved to Manchester with his mother, and he was an engraver. He actually started his own engraving business, and that helped him to finance his education and entered private medical school in Manchester, UK. Then he set up a private practice, but his interest was mostly in research, and he was also very much enamored by the summer catarrh or the hay fever. Himself was a sufferer, and he himself skin tested with several different substances, and he took the hay, which is the grass, and skin tested, found he had a huge, and the way he did it was he sort of scarified, he removed he actually scratched his skin with a blade and had an open wound and put the hay antigen on it, and he had a severe reaction to it. So that told him that there is something inside his body that was causing this problem. And that something outside he wanted to know was the grass. He was such an intelligent researcher. He knew there is something floating in the air. And he was the first one to start doing pollen counts. Can you believe that he was doing pollen counts in the early 1800s? And how did he do it? He would attach these glass slides with the glycerine, with the Vaseline, and mounted on it, and he would attach it to a kite and fly these kites. And he had what we call as tandem kites. Tandem kites are kites attached to each other, flying at different altitudes, because he knew that the pollen counts could be different depending upon what height it is being manifested. And also he came to know that wind speed can cause problems, sunlight could cause problems, and he also hypothesized that these pollens can travel hundreds of miles. And he was such a scientific genius that he even postulated that hay fever occurring in the ships across the oceans was due to pollens floating in the air. Now we have evidence to show these particulate matter or even the pollens can travel hundreds of miles. And this person alone did this over a long period of time. And he was nothing but what they call he was a one-man walking allergy laboratory. That is how one of the famous authors called him. Blakely was a one-man walking allergy laboratory. The next thing was Dr. Wyman. He was a contemporary around in USA, and he observed the same sort of symptoms occurring in the fall, and that was due to ragweed. And then he noted one thing, that it was running in families. So hereditary tendency of allergic disorder was detected way early in 1870s. And he observed another very important item, that is very few mechanics or farmers, that is people in the lower socioeconomic class, were not affected, but the people who were affected were all in the higher economic class. This was also this was also noted by Dr. Blakely, and these people who had this very luxurious lifestyle were the ones that were affected more than the people who were at a lower socioeconomic status, and that's what we still see. So this was observed hundreds of years ago. And then there was another very, very interesting experiment that was done by Dr. Dunbar in Germany. What he did was he injected the horses with these grass extracts and took the serum of the horses, made them as a powder. So he was postulating it had anti-venom, anti-serum in it. So antibodies was there inside that horse serum, which was actually in the powder form. And he would instill that powder in the nose and eyes every day and found it was very effective. It was effective. And then the people started having reactions to the horse serum protein, and then he started doing only the grass pollens extract. So he would boil the grass and dry it up and instill the grass pollen, and that is how the allergen immunotherapy started. And actually, it was started by a partnership. Dr. Noon, Dr. Freeman, Freeman visited Dr. Dunbar in 1911, and that is when the first scientific article was published on injection immunotherapy. So this is the early evolution of allergen immunotherapy was started in this manner in Europe, in Germany and UK. And over the next 100 years, they were treated with specific immunotherapy with different allergens, whatever they thought was causing the problem, but without knowing the mechanism. So without knowing the mechanism, they were treating this disease, allergic disease, in a successful way. And it's classical example of what we are doing now, and the example of what we call as a cart in front of the horse. The horse should be in front of the cart. Here, the cart is in front of the horse, and that is exactly what happened with asthma management, where we got incredible drugs like inhaled steroids was introduced in 1970s when I was just getting out of fellowships. And we were the first one to do the study on beclomethasone and in Denver. And without knowing the mechanism, what asthma is caused by, we were getting the best drugs on the market. And we still have many, many incredible drugs. We still do not know the full mechanism of asthma. Now, continued, Robert Cook in the 1900s found that he started doing intradermal skin testing, noted multiple sensitization in people, and he started active immunization. And in 1921, for the first time, that Dr. Kern noted that mattress dust also causes asthma. That is, when you take the mattress and you shake it up and the dust comes out, and that causes asthma. And Robert Cook, is the one who established that house dust was a major precipitant of asthma. And one Dr. Decker is the one who showed that there were dead insects in the house dust. Under the microscope, he saw some dead insects. He could not identify them until 1967. Imagine, almost 50 years later, those dead insects were actually identified as dust mites by Dutch physicians Dr. Woerhurst and group, and they were the ones in 1967 named it as Dermatophagoides stauronicius, it is like a common word for us, and we have several different genotypes of that. So this is the evolution of the house dust mite. And by that time, there was at the same time, contemporarily, they found that adding glycerin prolonged the patency. Then they came up with alum precipitated extracts. And one I want to spend a little bit time on one lady called Mary Hewitt Lawless in Connecticut, USA. What she did in the early 70s, and actually my chief, Dr. Jaime Chai and Dr. Middleton, would be very much in contact with this lady allergist who was in New York, in Connecticut is a neighboring state of New York. What she did is she is the first one to come up with this repository therapy. And more than that, the major contribution from her was with the insect allergy. she actually had two of her colleagues who were on whole body extract with Hymenoptera extract, whole body extract. That is how it was used. And both of them had severe anaphylactic reaction when they got stung. And that actually made her, she was convinced that whole body extract was not effective at all. And even the American Academy of Allergy was a proponent of whole body extract. And what Mary Hewitt did was she grew a huge garden in the back of her house, and that garden attracted a lot of bees and wasps and yellow jackets. And what she would do is pick these insects from her backyard, bring it into her small lab inside the house, and take out the venom sac, extract the venom, and she would make up. She actually was extracting 500 to, she would catch around 500 to 1,000 of these bees every day and extract it and made a first honeybee venom extract and injected that in dilution and found that was highly effective. And that is how the bee venom extract or the Hymenoptera venom extract came into picture. And she published a very famous article in 1957, actually. I mean, 1977. And that was actually rejected by the scientists then, and finally was approved by the American Academy. So only in the past 40 years we have the venom immunotherapy. Before that it was whole body extract. It was due to the original um, work of Dr. Lovelace, which made the venom immunotherapy available to us today. And there was also, we played around with these bacterial vaccines, with this, what we used to call it asthma as exogenous, endogenous asthma, mixed asthma. It was also called infectious asthma. So bacterial vaccines were used for a while. I have personally used it also. And it was sort of mixed results. And we did not have any exactly, I was not very familiar with major studies done, but the studies showed it was almost as like placebo. So then it was discontinued. Now, the major step has happened between 80s and 90s, and now we are at the recombinant technology with enhanced safety, convenience. So at the same time, we also have different treatment schedules which were there before too, which was called pre-seasonal, co-seasonal, perennial, rush therapy, and they all have found they have their own advantages or disadvantages. But perennial immunotherapy was found to be a lot more effective and safer than pre-seasonal or co-seasonal immunotherapy. And rush immunotherapy was started in 1930 and was also quite effective both immunologically and clinically, but had much more risk, almost 30% risk of systemic reaction compared to 3% risk with the regular schedule. So with pre-treatment, you can reduce the risk rate from 30% to 3%. And immunological breakthrough, as I was telling you before, occurred in 1968 by the Isizakas. But one of the major breakthrough that happened in the field of allergy was 1921, was what we call as a PK reaction. It's actually my initial. It's called passive transfer of reagent. There were two scientists, French scientists, Prosnis and Kushner. One of them was highly allergic to anemone, which is start of a sea, like a fish, like a seafood, highly allergic. He would get anaphylactic reaction to it. So what did Prosnis did was he transferred his serum to Kushner on intradermally and had Kushner feed. Kushner was not allergic to fish at all. He would eat that fish without any problem. He ate the fish, but developed a significant local reaction where the serum of Prosnis had been injected intradermally, which revealed that there is something in that the serum of Prosnis that had been passively transferred to the forearm of Kushner, and that passive transfer was called reagin, and that reagin was detected to be what is called IgE in 1968 by Isizakas, and the following year by Johannesson and Benich in Uppsala, Sweden. And later on, we found that we also developed, we found that people who go on immunotherapy developed a different type of IgG antibody called AGG4, which has been called a blocking antibody at that time. And there were some very interesting studies, revolutionary studies done in immunotherapy, which nowadays you cannot do because ethically they are not right. One example was Dr. Lowell and Franklin at Mass General Hospital took around 24 subjects and they treated them successfully with mixed allergens. And what they did was, in the middle of the treatment, they removed the ragweed from the treatment set, and or they reduced the quantity of ragweed in the vaccine, and they found that removal or reduction of the ragweed actually had lesser effect on the immunotherapy compared to the full extract. So what happened basically, and this slide is showing the score of the symptoms. There is one untreated. This is the one where is the untreated is the one that is the broken line. Treated is the solid line. You can see that the one with the full extract, it was highly effective. One where the ragweed was removed was partially effective. One there is no pollens at all, there was not at all effective. Where there was no ragweed at all, it was not at all effective, and that was only during the ragweed season, that is from July through September they were looking at. And what they found for the first time scientifically, they showed that allergen immunotherapy was effective. It is effective even when there's a mixture of antigen, and it is terribly specific. It's incredibly specific. If you remove the ragweed antigen, there is no more effect on the ragweed effect if you are not treating with that, unless you have treated it over a period of time. This was at the beginning of their immunotherapy. There was another study done by Dr. Douglas Johnstone in 1963 in Rochester, New York. It was a pediatric study. He was a pediatrician. 210 children were tested, and they were all positive to inhalants, and they probably had a history suggestive. And he randomized them into two groups. He did not tell anybody. He did not tell the parents, he did not tell the patients, he did not tell the staff. He's the only one who knew what that randomization was. And one group really got only saline or extremely dilute extract. Next one had an intermediate extract dosage. Third dose was a high dose extract group. So three groups, and he treated them for 4 years. For 4 years, nobody knew what extract they were being treated. And he found that the group that was treated with very dilute extract or saline, only 18% of them were free of asthma developing, and intermediate group, 58% of them got free of asthma. High dose group, 81% free of asthma, and possibly allergies along with that is probably coexisting. So what it showed was the higher the dose, it was much more effective. That is what he showed. Such studies cannot be done now because you cannot just blind everybody. No one except the principal investigator knew. So you cannot blind. So it is unethical now. So the reason I am sharing this is these are the pioneers who took upon themselves to prove something significant, which is very useful for us today. So then the oral immunotherapy came, which was proved not effective. SLIT has been around, and and we all know it is incredibly effective. And 1998, WHO actually approved SLIT, and they suggested, oh yeah, it could be a positive alternate to SCIT, but it took a while before that happened. Although in Europe the progress was very, very fast. There were 100 random double-blind placebo-controlled studies done in Europe, but they were all monotherapy. They were not multi-antigens. And then around the early 21st century, SLIT tablets started coming, fastly dissolving tablet. Now, for the first time introduced in India in the past few months. In the USA, it came in 2014 with the 5 grass mix and ragweed. 2017, dust mite was approved and released, but there is no approved liquid preparation for SLIT in the US or in Europe, there's no, so none of these drops are standardized or approved, or we don't know what is that the potency is. Now, a few interesting data I want to share. I don't know if I have a few minutes time. I want to tell you that mucosa, if you take the oral mucosa, actually mast cells and dendritic cells, that is antigen presenting cells and mast cells, are much less in the oral mucosa compared to mucosa elsewhere. And they are much deeper in the subepithelial layer. And that is one of the reasons oral mucosa is 100 to 1000 times more tolerogenic than the skin. If you take the skin and look at the type of, the amount of mast cells, and we call it the dendritic cells, antigen presenting cells on the skin, they are highly concentrated, whereas in the oral mucosa it is many tolerogenic type of environment, tolerogenic cells, very few mast cells, few dendritic cells. So sublingual area is much more efficient than than oral due to digestive enzymes. So allergenic reactivity of the oral mucosa is low, and that is one of the advantages for us to do the sublingual immunotherapy. Now, there is another thing you need to know. The mast cell and the dendritic cell concentration varies between in between the different areas of the mouth. There is high the mast cells and Langerhans cells, that is called the antigen presenting cell ratio, in the vestibular area of the mouth. Vestibule is the space between your lips and the gums, and so that is where most of the mast cell, the I mean the sorry, the antigen presenting cells are. The ratio of the Langerhans cells to the mast cell ratio is high. That means there is a lot of antigen presenting cells present in the vestibular area compared to other areas of the mouth, and that is exactly what we want in sublingual immunotherapy. We want the antigen presenting cells to pick up the antigen and take it to the T cells to cause the IgG production through the B cell. So it may not be a bad idea to squish the slit content around the mouth so that there is more contact of the slit antigen rather than just keeping it under the tongue. And as far as slit analysis goes, extremely safe. If you look at slit, out of 1 billion doses, slit, in addition to causing local reaction, can cause some mild systemic reactions also, but never has been needed epinephrine dosage. But just a warning here is slit can cause systemic reactions. It is not 100% safe. That is the message. And slit can also cause a major medical issue, a condition called eosinophilic esophagitis. If somebody is prone to it, if your patient is complaining of stomach pains quite a bit, which is not relieved and it continuing, and they are also having a little bit hard time swallowing the food, suspect eosinophilic esophagitis, and slit antigen can propagate it and make it worse. And SCIT, as we know, can cause systemic reactions, 3 anaphylactic reactions every 100,000 injections. And the main reason why immunotherapy can cause systemic reaction, 88% of them, of these survey they did during different years due to fatal reactions, 88% of these patients who received allergy injections and who died had unstable asthma. So if you have to have stable asthma before you administer either SCIT or SLIT, so that means you definitely have to make sure that you talk to the patient. Are you okay? How has been your asthma control? And do a peak flow meter before SCIT for sure. Sometimes even a smart thing to do before SLIT also. SLIT generally is much safer than SCIT. The first dose should be administered in a doctor's office. Whenever there's a fresh dose, the vial of SLIT is coming, please administer in a doctor's office, because it has been noted that systemic reactions, if at all they occur with SLIT, it occurs in the first dose. And so that is why we have them wait for 30 minutes. Even in the house, when slit is administered, make sure the patient doesn't disappear. The child stays in front of the mother, and mother should be aware of it and should be present. The child should be present in front of the mother for 15 to 30 minutes after a slit dosage. And FDA makes it mandatory for us to have epinephrine available even for slit, definitely for skit. No eating or drinking 5 minutes before slit. And a few major studies, very interesting studies, have shown that immunotherapy, we know, causes immunological changes which are very favorable to us. And it also causes clinical changes, but and also causes molecular changes. But what has been shown in this study, which just appeared a few years ago, a Japanese study showed structural changes. For the first time, structural changes have been exhibited by sublingual immunotherapy. Sublingual immunotherapy given over a period of 3 years with strength of 6 micrograms of HDM slit was given to these patients and showed there was a significant reduction in airway wall thickness, an increase in the airway caliber, an improvement of pulmonary function, improvement in asthma rhinitis in this group of patients. And some of these changes occurred within 6 months. So, which means that slit, and this is showing an inverse relationship between the FEV1 FVC ratio and the airway thickness. As the airway thickness decreased, the lung functions improved in these patients. And so what it is showing is now we are coming to a stage where we are showing that this immunotherapy is not just should be reserved for mild patients of asthma or allergic rhinitis. I think we probably should start impressing our colleagues, pulmonary colleagues, that this could be a modality that could be used in grade 3, grade 4 asthma. If it is if allergies are playing a major role in these patients, immunotherapy is not a bad deal. It could be effective in different grades of asthma as long as allergies are playing a big role. So it is very, very safe and equally effective. And another new thing that has also come out is that omalizumab, pre-treatment of omalizumab, AIT can be used even in the severe asthma after pre-treatment with omalizumab to increase the safety, reduce the reactions. So this can be effective. A treatment in moderate to severe cases of asthma along with omalizumab. So this is something we need to start thinking about. And this study is showing that earlier you use, more effective, especially for pediatricians. The earlier you test, earlier you start therapy, immunotherapy seems to work better and prevents the progression of allergies to asthma. So this is what we call as a window of opportunity. Starts around very early, around the age of 3 years, and goes until the age of about 6 or 7. So do not delay immunotherapy until the child is 10 or 12. By that time, remodeling has completely settled in their lungs. So start early before the problem start, before even the asthma occurs, or when there is subtle signs of asthma with night cough or physical activity coughing, even with normal lung functions. So conclusions. So, as I have spent in the past half an hour, AIT has evolved significantly since its inception, 1911. It is firmly placed and it is approved. There is significant amount of good acceptance in spite of the above, in spite of all these things. What is the what is it, compliance rate? Extremely low, 7% in slit, 23% in skit. So what the studies that they did showed, it is the frequency of education that made the difference. So very, very important practical point for you is once you start on allergen immunotherapy, do not tell the patient, okay, I have done everything for you, I have started you the right treatment, see me in 6 months, see me 1 year. That is the main reason why low compliance is there. So studies showed that if you see the patient every quarter, every 3 months, 72% will comply. If you see them every 6 months, 38 to 40% will comply. If you see them more than 6 months, only 18% supply will comply. So what it means is you need to see the patient, or nowadays with the modern technology, with the with iPhones, with these smartphones, have your staff call these patients. I say every month for the first 6 months, every 2 months for the next 6 months, every 3 months for the next following 6 months, and then every 3 to 6 months after that. So this follow-up therapy is most important to make sure the patient are compliant. So, and the last thing, SLIT is not effective in multi-allergen mixes. SCIT is effective. So I'm going to stop with sincere respects and gratitude to my teacher, who is Dr. Nelson at Jewish Hospital. He's 94 years and still runs. He goes on a walk for 3 kilometers every day. And he's the father of modern allergen immunotherapy. Thank you.
Thank you, Dr. Veteran sir. This was an excellent presentation on the history and evolution of allergen immunotherapy in children. There are a few questions. One is, what should be the minimum age for starting allergen immunotherapy?
Minimum age, is 5 years accepted. But
Right.
if you have a very bright child who can keep that pill or the drops, even 4 years is fine.
Right. So we'll take the questions in the end of the other lecture, sir. So I would like to now
How
invite.
do I stop these slides? Let me see. Can I stop the sharing? Yeah.
Yes, yes, yes.
Okay.
Yeah, it's done. So I'd like to invite our next speaker, Doctor. I'd like to introduce Dr. Tara Asaf Qureshi. He's from.
Can I leave now because I need to go?
Okay, okay, sir. Neeraj.
Thank you.
Yeah, yeah.
Sir, we will be having certain questions for you in the panel discussion. Is it possible for you to come back after some time? Vedantan sir?
I think he's already left.
I think he has already left. So no problems, no problems. We can continue.
Okay, so I would like to introduce Dr. Taha Asraf Qureshi, who is a bright pediatrician and allergist from the beautiful state of Kashmir. He is practicing in Jawaharlal Nehru Hospital in Kashmir and is an emerging voice in allergy and immunology with a strong interest in the immune mechanism pathways underlying the allergen immunotherapy. With a clear focus on the immunological pathways, he brings to us the cutting-edge understanding of how allergen immunotherapy works, influences the immune regulation and tolerance. So Dr. Qureshi will be speaking on the inside the immune dialogue, how allergen immunotherapy rewires allergy, and how it is expected to simplify complex immunological insights into the practical clinical relevance for daily practice. Welcome, Dr. Taha.
Thank you, sir. Thank you so much. I hope I'm audible.
Yes, yes, you are clear.
Right. All right. Thank you so much. Well, after this PK sir's scintillating lecture, he is a legend, in fact, and so I proceed with caution and humility, because it's my turn not to embarrass myself now. So, how allergen immunotherapy rewires allergy? Do we need to fix allergies? That's the point I want to make. I'm in a little trouble. Just a moment. Yeah. Yeah. So, why to rewire allergy? The question is that every third person we see is suffering from one type of the allergy or the other. Children and adolescents, this trend is rising. Then, of course, these are progressive diseases in nature, and there's need for long-term solutions. And the long-term solutions, what tops that all is the allergen immunotherapy. And to understand that allergen immunotherapy, what all we need to do is to learn at least the basic mechanism, how allergies happen in our body, the pathophysiology, what we need to see. So normally, I hope the screen is visible.
Yes, visible, but in the right.
Dr. Taha, on the right side of the screen, there is something which is coming, like some ad is
Yes.
coming. That is why the slide is not completely visible. Can you please
Yeah,
remove this ad?
I'll just try to do that. Okay, sir. I think I hope things are okay now.
You need to share the slides. We can't see your slides.
Is it visible, sir?
No, we cannot see your slides. Please share your slides.
Yes. So the ad is not going away. Can I do it like this? In this mode?
We cannot see your slides.
I will share that. I'll share it, sir. It will not be in a presentation mode. It will be something like this, sir.
Okay, can you present it like this mode only?
Yes.
Yes,
Yes,
please,
sir.
that will be okay. Please do.
All right. All right. So, normally the Th1 cell immune cell response predominates in a normal person who is not atopic. The Th1 is actually, there are two types of, CD4 cells or the Th cells, T helper cells. One is the Th1 cell type, Th1 type of T helper cell, and the other one is the Th2 type of helper cell. The Th2 cell immune response does not predominate in normal individuals. It predominates in the atopic individuals in itself. We'll be coming to the details later. So Th1 cell immune response is actually, anti-infective. This is, but Th2 cell predominant cell immune response is usually pro-allergenic, and we need to have a Th1 strong immune response to be normal, to be non-allergenic. So this all starts with this antigen presenting cell. I have, actually I had made this animation so that, everybody could understand it. So my cursor will just, I try to do it with my cursor now. This antigen goes to an antigen, whenever we are exposed to an antigen, the antigen presenting cell receives it in our skin. Then later on, the second step is this antigen and antigen presenting cell, this combo. What happens is that they actually dimerize with the Th2 helper cell, and this Th2 helper cell gets activated, and if this activate Th2 cell helper cell, this produces interleukin 4. Interleukin 4 is the most important cytokine, which is responsible for causing allergies in most of the individuals. Then the other interleukins like interleukin 13, interleukin 9, 2, 15, etc., they have a secondary role. Primary is the interleukin 4 molecule that is actually what activates the B cell to form antibodies, which actually are class switched antibodies. B cells are primarily predisposed to produce immunoglobulin G and immunoglobulin M antibodies. But it is the interleukin 4, which is produced by these activated T cells, that this B cells, they tend to form immunoglobulin E antibodies instead of immunoglobulin G or M antibodies. And this IgE antibody, this goes up and, this sits on the mast cells. And oh my God. I'm really sorry, my ads are, causing trouble over here. There's something wrong with the system over here. I will have to wait a little. Okay. Then these mast cells, once IgE cells sit down on the mast cells, they are called to be sensitized. And these sensitized mast cells, once this new antigen exposure occurs in an individual, they don't now interact with antigen presenting cells. They they straight away, interact with this IgE sensitized mast cell, and there's a dimerization of IgE antibodies and internalization of this receptor, what it calls, internal message sent across, which causes mast cell degranulation, which produces lots and lots of mediators, especially histamine and many other enzymes that cause allergic reaction in our body. And this is what an atopic individual is susceptible to happen. This is just the overall scenario, what happens first allergen exposure, then this is a repeat of what has been shown in the previous slide, but in a formulated way. You can see first allergen exposure, then T cells, then B cells, then on the right the plasma and memory cells which secrete antibodies, class switching of IgE, of course, and later on histamine release in response to a second exposure to an antigen. Now, how do we manage these allergies? Of course, pharmacotherapy is the key to after we do the avoidance of allergens. Avoidance does help, but compliance and other issues are there. Possibilities are not too much to be very compliant, and in the of course this pharmacotherapy has to take over. And pharmacotherapy does give some symptomatic relief, but the primary this nature of the disease, if something has to do with that, and that will be immunotherapy. Apart from that, biologicals have some role, but immunotherapy is ultimately what gives you induces long-term tolerance in us against these particular allergens. So what is AIT? It's a controlled exposure to these allergens, in different concentrations by different routes. PK sir already talked about various these routes, how it's given in the present world scenario, starting right from 1800s and later on. And this is given to induce such an immune tolerance over time, so that the normal routine exposure, environment exposure of these antigens to our body does not cause any symptoms and does not make this disease to progress, and it further prevents new sensitizations as well. Well, these are different routes. The first three routes are presently in vogue. They are in practice: subcutaneous immunotherapy, sublingual immunotherapy, OIT to some extent. The other routes of immunotherapy have either been, have either happened in the past, intradermal one, or they are presently into research. Well, the benefits of this allergen immunotherapy, the only scientific modality that has a curative potential, then Th2 status changed into Th1 status, which we talked about earlier, and of course, the impedance of it impedes the onset of asthma when there is allergic rhinitis, and polysensitization, new sensitizations too are prevented with immunotherapy. Well, if we talk about the history overall, PK sir, gave the whole description of this history, and I thought I would teach you a few words, but tell you a few words regarding history, but PK sir gave the whole dictionary. I'll just start with this one. King Mithridates VI, he was also called a upator, and he had used increased doses of snake venom to make himself immune against the toxin. And we are not very sure whether he was successful on this or not, but literature gives, a reference of him as one of the person who had this concept much earlier in 132 to 163 BC itself. And later on, there have been lots of other discoveries, and in which, 1565, we started Leonardo Botello, who described seasonal allergy, and then the list was endless. PKs have already talked about all these discoveries one by one, in fact, many, many more, till 2002, and onwards. In 2002, 50% of immunotherapy in Europe has been sublingual, and nowadays, it has crossed much beyond 70% in the present world. Well, coming to actual, the target for our allergen immunotherapy. What are the target areas? The most important target area is the T cell, because T cell is believed to be the master cell in our body causing allergy. It's not the B cell, it's not just the IgE, it's not just the eosinophil or the other cells. It is the T cell, which is called as the major symptom, orchestrator of this particular crime called allergy. So T cells are the primary target for allergen immunotherapy and the long-term target. Then, of course, allergen immunotherapy affects mast cells, it affects eosinophils, it affects B lymphocytes and IgE antibodies as well, but they are the secondary target. The primary target is the T cell. We'll be dealing with them one by one. You can see in this diagram, this sublingual immunotherapy or the subcutaneous immunotherapy ultimately affects the nearby, the regional lymph nodes in which the nearby lymph nodes and the dendritic cells present nearby. What happens is that the dendritic cell subsets, at the place of administration, whether sublingual or subcutaneous, they actually convey a message to the Th1 cells to become active, and then they increase the number of T regulatory cells, increase the number of TR1 type of cells, then which all actually by secreting different cytokines like interleukin 10, like TGF beta, and many other cytokines. What they do, they activate all types of cells, starting from B cells. You can see interleukin 10, which is produced over here. That interleukin 10 stimulates the B cells, the antibody forming B cells, to form the protective antibodies, the IgG4, which act as a blocking antibody for the immunoglobulin E. So the race between immunoglobulin G4 and immunoglobulin E is won over by immunoglobulin G4 after some time of starting this allergen immunotherapy, and hence that gives a very good curative relief. Later on, in the course of this treatment, interferon gamma takes over, the Th1 system starts predominate, and these T regulatory cells, Treg cells in short as we call them, they produce interleukin 10, interleukin TGF beta and others, which actually they actually suppress the production of various cytokines which are pro-allergenic, like interleukin 5, interleukin 4, 13, 9, 13, even 35 to a great extent, and that's how these mechanisms of producing immune tolerance take place. Then coming to how does this AIT work? Starting actually, this is the timeline. How it is? When does it start working? The best part about allergen immunotherapy is that it starts from the day one. You can see this blue line over here. Over here, this says that from the day one itself, when we start allergen immunotherapy, there's a decrease in tissue mast cells and eosinophils and release of their mediators. This is what happens because of allergen immunotherapy from day one. And later on, the other things like early decrease in mast cell and visual activity for degranulation and systemic anaphylaxis takes place. In fact, it's against these processes. This desensitization starts, and finally, for a long term, you can see this pinkish line as well. This is the bluish line is the one way where it starts first. Later on, this saffron line, which actually indicates the mast cell and basal activity, and find this blue line means that this T cell tolerance, it starts beginning and allergy comes crumbling down. And so the best part of allergen immunotherapy is that it starts this action from day one, but an appreciable action takes a little time, around 6 months or so in case of subcutaneous immunotherapy, and around 6 months to 1 year or so in case of sublingual immunotherapy. Subcutaneous takes around 6 months. So coming to this one by one, these areas where immunotherapy works, IgG4 versus IgE, I told you it's a tug of war between the two. It ultimately has to be won by the IgG4, the blocking allergen, which, from binding to IgE, this stops these antigens, and that's how this axis immunotherapy acts at this point of time, at this point of the step. Then, as far as the mast cells are concerned, there's a decrease in the release of mast cell mediators because of this allergen immunotherapy. Histamine decrease, then of course the TAME molecule, the tosyl-alarginine methyltransferase, the enzyme that activates the kinin system, that also is decreased inside the mast cells, and the prostaglandins also, the mediators present inside the mast cells that cause long-term allergies, late phase reactions, they are also blocked by allergen immunotherapy after some time. Well, at eosinophils, what does the mast cell do? It decreases the eosinophil cationic protein, which is a very important toxin present within these cells. And it further decreases the eosinophilic further recruitment and influx of the cells, and therefore, gives a lot of tolerance, causes a lot of energy, not the allergy part. So T lymphocytes are the ultimate target, and I told you that, it's the CD4 cells from the Th2 side which predominate, in case of allergies, and to make them shift to Th1 phenotype. This is what AIT is all about. And there's a down regulation of the interleukin-4 production from T cells is because of the T regulatory cells, which cause production of increased levels of interleukin-10, interleukin and TGF beta. They all are a pro-Th1 response, and even interferon gamma, which again has a pro-Th1 response. Cytokine production causes this Th1 type of response in our body. It induces that, and actually this takes over a little few months after starting immunotherapy, but this is it is what gives a long-term relief against allergies. And the class switch, which had happened earlier on, that there's a reverse class switching later on with this because of the action of regulatory T cell. What happens is that there's a reverse class switch. What earlier on interleukin-4 had caused B cells and plasma cells to form immunoglobulin E instead of IgG and IgM. Now, with the advent of allergen immunotherapy, we start beta B cells start forming IgA and IgG antibodies, especially immunoglobulin G4 antibodies, which are protective. So the crucial role of regulatory T cells we talked about earlier also suppresses the Th2-driven allergic inflammation and promotes immune tolerance. And this is the key to the allergen immunotherapy success. Actually, in normal people, there's a balance between this Th1 and Th2. Th2 predominates overall. And in an allergic patients, we said, you can see there's an imbalance. And when allergen immunotherapy is introduced into these allergic patients, a specific allergen immunotherapy, this balance is restored. That's how it is. So if we summarize these things, there's a decrease in Ig-dependent mast cell activation, then suppression of type 2 immunity, the regulatory T cells come over, and which actually have the major role. Type 1 immunity has to predominate. Local systemic and systemic IgG, IgG4, IgA come over, and of course, there's another factor to it. This allergen immunotherapy not only makes our adaptive immunity better, anti-allergenic. It also helps our innate immunity in the sense that type 2 dendritic cells, which are always there to produce anti-allergic cytokines, they also are activated by allergen immunotherapy. It's not just the adaptive immunity, it's the innate immunity as well, though to a lesser extent. And innate lymphoid cell as well, they are affected. They ultimately act upon the type 2 dendritic cells. Now, timeline, if we come timeline, we already talked about, it takes weeks for the mast cell deactivation, then weeks for the histamine release decrease, then months for the decrease in immunoglobulin E. In fact, earlier on, there's an increase in the immunoglobulin E levels because of the introduction of the immunotherapy, because they are allergens themselves. Later on, there are blocking antibodies, IgG4 comes up, and the overall IgE levels, the specific IgE levels, they come drastically down. And it takes 1 to 2 years almost for T cells to, especially for the sublingual immunotherapy, for the Treg cells to come up and show their effect, the long-term effect. And overall 3+ years is a long-term allergen tolerance. And coming to the long-term effect of immunotherapy, lots of studies have been there. This is one study which was a double-blind placebo-controlled trial of grass pollen immunotherapy. Over a period of 3 years, the patients were observed 3 years post finishing the 3-year immunotherapy or 4-year immunotherapy. 3 groups were actually followed over a 3-year period of time after immunotherapy was completed. One was who continued maintenance immunotherapy in full. The second group was who received only a placebo injection, and the third group who had never been treated with immunotherapy. So the results were here. This was actually done by Durham et al. 1999 publication. This is, you can see these graphs. You see this one, this is actually the group. This one is the saffron one is the group which received immunotherapy. You can see their symptom score on the y-axis. The symptom score is plotted on the x-axis. These are the months. You can see these are the seasonal changes. You can see this immunotherapy group has much less symptom score compared to the group which is a placebo group over here. From on the other hand, you can see these 3 groups. The saffron group is the one who discontinued it. This one is the middle one is the one who took no immunotherapy, and the upper one sorry, the upper one is the one who took low immunotherapy, and this middle one, the middle one is this one. It is the maintenance dose. You can see this always had much less symptom score compared to the groups which received none of the treatments. All these three you can see different seasons. This is 1993, then 1994, and 1995. You can see this is post immunotherapy 3-year study, one of the leading studies, which actually proves that long-term effects of clinical efficacy of grass pole immunotherapy is always there. There are some studies which have been actually studied it post 5 years, post 10 years, and even post 15 studies are presently there in the literature, but the sample size is a little less. So I thought this study was a better one than those particular studies. So the clinical outcome, we already talked about long-lasting relief. Asthma doesn't happen, or even if asthma is there, it doesn't progress. Then decrease in medication use, symptom score, and it prevents neosensitization as well. That's what's the outcome of this. And we treat the root cause. We don't treat symptoms. Immune rewiring happens, of course, and that happens via the mechanisms we earlier talked about. The long-term immune memory gets modified, and the disease progression, which has to be prevented. That's our target. That has to happen. Thank you. I'm sorry for the technical glitch that happened, but I hope I was clear on this.
Your talk was excellent, Dr. Taha. It came out very excellent, but technical glitches always happen, so don't worry. This is very informative talk. There are a few questions, but I would like to just take up one from the YouTube. There's a question from Dr. Brinda. Why is there the initial rise in specific IgE following allergen immunotherapy? Why there is the initial rise in level of specific IgE in the initial part?
Actually, what we are doing first, what is allergen immunotherapy? It's the same antigen in diluted forms which we are giving to the patient. Obviously, the moment we give the same allergen to the patient, of course, they are diluted, but you are giving the allergen. And once he's receiving this antigen, extra apart from what he's receiving through the environment. Obviously, initially, the response of the body has to be producing more antibodies. The response has to be that only, because directly, what happens is that our body, there's a feedback mechanism in the body. The moment these the allergens come, they are received by our bodies. What happens is that the machinery production. Where do these come from? They come from interleukin-4 and other things. All these mechanisms are activated initially, and they come up and produce more antibodies. But later on, when the other mechanisms take over, they suppress this antibody production.
Right. So simply speaking, in the initial part, because of the allergen, there's a rise in the IgE as the body gets tolerant to the antigen. So the IgE levels will come down. So that is the simple message. So there are a few questions we'll take at the end of the talk. Okay. Thank you, Dr. Taha. That was an excellent session.
Thank you very much.
Okay. So I would like to invite our next speaker, Dr. Spurti Reddy Chitta, who is a very dynamic. Dr. Spurti, are you here? Yeah.
I'm here, sir.
Yeah. I'd like to welcome Dr. Spurti Chitta Reddy, who is a very dynamic young pediatric allergist practicing at Rainbow Children's Hospital, Hyderabad. She's trained in the USA. She's a fellowship pediatric of the American Academy of Pediatrics and trained herself in immunology from Singapore. And she is one of the faculties of the course run by Matrain. So she's got a very keen clinical acumen in identifying the right patients for allergen immunotherapy, and she has contributed to various national and international academic activities on allergy care and patient selection studies. And also she is a big contributor in the field of allergy education. So she will be talking on who, when, and why regarding the clinical gateways in allergen immunotherapy, and will guide us to identify candidates who will benefit most from the allergen immunotherapy and decision-making involved behind the process. So welcome, Dr. Spurti. Please start your talk.
Thank you, sir, for that very nice words. Um, um, we had a very inspiring talk by Vedantan sir, and we also had a very, very informative talk by Dr. Qureshi ji. And now we'll delve a little into the who, when, and why of allergen immunotherapy, and also some practical clinical gateways to immunotherapy. So, we first began with the objectives. So let's understand the current indications and patient selection
Dr. Spurti, Dr. Spurti, can you please go to slideshow?
Okay, sir. Actually, I'm in slideshow only. Okay.
We're still not yet in
It's seen
slideshow.
as slideshow, sir, to me.
Okay, no worries. You please continue. No worries.
Let me just, can you just unshare and then try again? Stop
Yeah, I
share.
think,
Try.
yeah.
Okay. Is it a slideshow, sir, now?
It is not a slideshow, but it's okay. You please continue.
Okay. So we're trying to understand the current indications and patient selection for AIT and discuss some evidence-based clinical gateways, and also we'll look into the global and guideline-based perspectives. So basically the mechanisms have already been discussed in detail by Qureshi sir, so we're not going to really go into that.
Dr. Spurti, sorry, but your slides are not moving. So I think you need to click to the respective slide and then it should start moving.
Okay, I'm sorry.
So you are still on the first slide, stuck here.
Is it moving, sir, now? Because to me, it is a slideshow actually.
Yeah, but actually it is not moving.
It's not moving. Okay.
You try sharing once again.
Okay.
Yes, now it is good.
Now it's good. Okay. All right. With regards to the indications for AIT, it's basically for the management of IgE-mediated disorders, as in allergic rhinitis, rhinoconjunctivitis, and also for allergen-induced asthma, which is controlled. And when it comes to atopic dermatitis, the allergy bodies differ. I mean, the American one and the European one. Basically, the American one says that there is some evidence for atopic dermatitis if they have sensitization to aeroallergens. And it's also indicated in Hymenoptera and fire ant hypersensitivity. So coming to the special population again, it is very safe in children. It is very effective and also well tolerated. And it should definitely be considered along with pharmacotherapy and allergen avoidance for allergic rhinitis, allergic conjunctivitis, asthma, and insect allergy. Now, coming to a very important population, which are the pregnant women, allergy immunotherapy can be continued if it's already been initiated. And doses are not increased and sometimes reduced during pregnancy. As I've told you, it's not initiated, but it can be continued if it's already been there. I'm just going to try one last time with the slideshow, sir.
Yeah, please.
Can you still see the slideshow or not yet? Because to me, it's seen as a slideshow. No, okay. All right. So now coming to a very important aspect of why do we consider AIT? Because we do not want to treat just the symptoms, but we would like to treat the cause. So many a times when patients ask us or the families ask us, so is this for lifelong and is there any cure? Then we would say that AIT is not a cure, but definitely it is as close as it can get to a cure. and it would modify the course of the disease. It definitely reduces the medication use and improves the quality of life. It prevents progression from rhinitis to asthma. It also prevents new sensitization to allergens. It definitely reduces the side effects of excess pharmacotherapy. And we also see that there is persistence of clinical improvement even after stopping AIT for several years. So mechanisms of AIT, which has already been discussed very well by Qureshi ji. So very briefly, we just have to remember that it induces allergen-specific Tregs, reduces mast cells, eosinophils, and its reactivity. And it definitely shifts from TH2 to TH1 immune response. And we also see an early rise in specific IgE, but it's followed by a decline. So the long-term tolerance via immune deviation is seen. So then the other clinical outcomes, definitely it has an effect on oral allergy syndrome. So there are studies wherein there is when immunotherapy was initiated to birch pollen, there has been improvement in people who had oral allergy syndrome to apples. And it's also been shown that there is improvement in local allergic rhinitis. And it's also very interesting that there are some studies which has shown that there is effect on offspring. It's about a few years ago, there was a study offering immunotherapy to 180 patients, and the control group was about 170. And then they were all monosensitized to house dust mite, and immunotherapy was offered, which they've used for at least 3 years. And then, if they looked at the offsprings, there was significant decrease in allergies in children whose parents were treated with immunotherapy. And if both the parents were treated with immunotherapy, there is a much significant difference. I mean, decrease in allergy in the offsprings. And coming to neosensitization, there is a very nice study of children between 2 to 6 years. This is basically a case control prospective study wherein it is basically of children who are monosensitized to house dust mite, who are all asthmatic. So half the population in the control group were not given immunotherapy, and half the population was given immunotherapy. And these children were followed up 3 years after 3 years of immunotherapy. And then they've noticed that um, at least 45% of children who has received immunotherapy did not have any polysensitizations, meaning neosensitization. But then almost everyone in the control group who did not receive allergen immunotherapy had neosensitizations to one of or the other, as you see here, cat, dog, alternaria, and grass. So it's very much established that immunotherapy would prevent neosensitization to allergens. So what are the indications for AIT? I think we have just discussed. It's basically for allergic rhinitis, rhinoconjunctivitis, allergen-induced asthma, but we should always be very sure that it should be a controlled one. And atopic dermatitis from American Academy, but European Academy doesn't really endorse it. And for Hymenoptera, fire ant hypersensitivity. I think this has been done. And patient selection, who is a good candidate now? So, moderate to severe symptoms despite pharmacotherapy, and positive skin test or serum specific IgE to relevant allergens, and this has to always be established. And poor control or adverse effects with medications, especially because for many of these allergens, corticosteroids are being used. And the most important thing here is young population, or rather recent onset of disease before remodeling sets in. Like Dr. PK sir said, even if it's a 12-year-old, but if she's been having the disease for, let's say, 6 or 7 years, then the remodeling has already been, would have set in, right? So it's very important to identify young population or the recent onset of disease and start them on immunotherapy. So what are the contraindications? This is basically from the Yaki position paper. They said it is contraindicated in poorly controlled asthma. In fact, they say that the FEV1 should be at least 70%. And in active autoimmune disorders. And autoimmune disorders which are controlled, right, in remission, it's basically a relative contraindication. And pregnancy, as we've already discussed, AIT should not be initiated, but if it's already been there, it could be continued. And beta blocker usage, it's a relative contraindication, especially for SCID, because there are chances of adverse reactions wherein you might sometimes need the use of adrenaline. So that's the relative contraindication. And cardiovascular disease is also a relative contraindication. So now coming to a very important discussion here, the age considerations. So evidence supports that both SCIT and SLIT can be given to children 5 and above. But having said that, the recent update from the Galen and the European Academy states that immunotherapy should in general not be offered to children less than 5 years, but immunotherapy can be initiated in children less than 5 years if indicated. This is basically the practice parameter third update. And it also mentions that the indications are similar to other age groups. But definitely it should not be offered to infants and toddlers. And that's one reason why why PK sir has said that if it's a very bright child who can recognize and verbalize the symptoms, it may be considered in children less than 5 years, as young as 3 years too. And in adults, it can be offered to adults 65 and above also, but on a case by case basis, individually looking at the merits and the demerits. So when to start AIT? It's basically pre-seasonal for pollen. Especially if you want to do for grass, then you'll have to do it a little earlier than the season, than the pollen season for grass. And year-round initiation for perennial allergens. So when not to start AIT also is very important. I think by now we've all understood that during pregnancy, it should never be initiated, but may be considered, you can continue it if it's well tolerated, if it's already been initiated. And it should definitely not be started with active infection or acute asthma exacerbation. So the duration of therapy should be a minimum of 3 years, and this is recommended by all the allergy bodies around the world. And long-term benefit persists for several years after stopping immunotherapy. So the types of immunotherapy, I think we've already discussed in the earlier sessions, the subcutaneous immunotherapy, the sublingual immunotherapy, and the emerging one is intralymphatic immunotherapy, wherein ultrasound guided injections are given to the lymph nodes. And this seems to be very effective, but it's still in the research phase. So here informed consent is very important. You'll have to tell them the nature of AIT and alternative treatments, the potential benefits and risks, and most importantly, the cost associated with it, and also the anticipated duration of treatment, because many of the patients expect to see an improvement within a few days, not even months. So we definitely have to tell them that it might take several months to see some clinical improvement. The immunological improvement may start on the same day or in the few days itself, but clinical improvement might take several months. And if there is no improvement in 6 to 12 months, we definitely will have to reassess if the treatment should be continued. And this I'm just going to leave, and yeah, so this is basically for the safety of the and safety and to prevent the adverse effects of AIT. So it should always be given by a qualified physician and staff, right patient, vial, dose, schedule. All these things are very important, and we'll have to screen them for the FEV1, the control of asthma. And the first dose is always given in the physician's clinic, and definitely will have to be observed for at least 30 minutes. And suggested equipment, definitely epinephrine or adrenaline should always be there. Even if we repeat it with every session, I think it wouldn't be an exaggeration to say the importance of epinephrine to be present in a clinic, in an allergy, in any clinic, and definitely in an allergy clinic. And the biomarkers of discontinuation of AIT. So do we have any biomarkers? So right now, there is nothing currently available, maybe on a research basis, but not currently practically available to determine when SCIT or SLIT should be discontinued. And response to allergen immunotherapy should be evaluated periodically, and discontinuation should be considered after 3 to 5 years. But having said that, Discontinuing venom immunotherapy is based on severity of initial reactions during therapy, and duration of treatment, because this is one immunotherapy for venom that we might have to use it for several years, or in some cases almost through life. So now coming to the very interesting part of clinical gateways to immunotherapy. So let's go with case one. These are some of the cases that I had. So we have a 5-year-old boy with severe persistent allergic rhinitis with disturbed sleep. Predominantly, it's early mornings for the past 2 years. So this started at around 3 years of age. No history suggestive of asthma. And the skin prick test was positive to both DF and DP, which are the house dust mites. And there was only partial control with house dust mite control measures and intranasal corticosteroids. So here, what do we do? So we know that this is a young child with persistent allergic rhinitis, and we've already confirmed and established the sensitization to perennial aeroallergens, and we have also seen that there is inadequate symptom control with all the avoidance and pharmacotherapy. So this is a good candidate to start AIT. So in this child, the house dust mite immunotherapy was initiated for the past 15 months, and we have seen that there is reduced symptoms and also medication use. And most importantly, here we should recognize that it's a very young child, right? So early intervention with AIT would prevent the progression to asthma, because right now there are no symptoms suggestive of asthma, and it would also prevent neosensitization, because right now the child is monosensitized. So now coming to case two. So this is basically, I've had this patient very recently, 2 months ago. This is an 18-year-old male student from Ethiopia, and accompanied by mother who is a nurse. So this child, actually he lives in Ethiopia, but he's come here for his severe vernal keratoconjunctivitis. And he also has moderate to severe allergic rhinitis. And these two conditions have been there for the past 6 years almost. So symptoms are perennial. It's been there almost every day, and it's worse on waking up. And it is so severe that he couldn't attend school. So I tried doing a skin prick test, but couldn't do it because of his dermatographism. So I had to do the specific IgE levels, and DF was more than 100, and then DP was also close to 100, and mesquite, the Prosopis juliflora, was 0.8. And I've also done a few pollen. It was negative to grass. Weed I've tested for Parthenium, mugwort, and tree pollens. It's important to recognize that the flora from Ethiopia is very different from India. But then I've shown him some pictures to identify certain trees. So it seems that mesquite is very prevalent there. But then it's not hugely positive. It's 0.8. So the other pollen were all absolutely negative. And so this patient, he's had several doses of intranasal corticosteroids for his persistent allergic rhinitis, and he's still been using ocular corticosteroid, like the eye drops. So here again, coming to the indication for AIT, it is still the persistent severe allergic rhinitis is the indication to start this patient on AIT, and not the vernal conjunctivitis, because vernal keratoconjunctivitis is basically a tricky disease which is a mixed reaction. It's both IgE as well as non-IgE, but in this case, because he's heavily sensitized with house dust mite, so we are in a hope that this would probably be an added benefit to his vernal keratoconjunctivitis. I've just started him on the sublingual immunotherapy tablets. It's just been close to 2 months, so we'll have to watch. And so we have the case 3. I'm so sorry for the small font. It was supposed to be on the slide show on a bigger size, but I'm sorry for it. So this is a 13-year-old girl presented at 10 years of age with moderate to severe allergic rhinitis and severe, it was basically uncontrolled asthma at that point. And but once we started her on controllers, I put her on budesonide formoterol, 201 puff twice daily, and then she seemed to respond very well, and then stepped down gradually to BID dosing and once daily dosing. So currently the symptoms were well controlled and the spirometry was normal. It was FEV1 was 82% in fact. And but the symptoms of asthma, I mean the asthma is well controlled, but there has been persistent allergic rhinitis with poor sleep, difficulty concentrating in school. It definitely affected her quality of life. And the skin prick test to house dust mite and cockroach both were positive. So in this child, we know that it is severe persistent allergic rhinitis and she has asthma, but it is very much well controlled. And house dust mite sensitization. So this is again an ideal child for AIT to house dust mite. And I think we all know that cockroach, basically we try to do avoidance measures rather than starting them on immunotherapy. So this is what has been done. And in this child, AIT definitely decreased the asthma exacerbations. It improved her quality of life and reduced the use of intranasal corticosteroids. And she's actually now off controllers for asthma. And this is a 11-year-old girl who was actually born in the USA, moved to India 3 years ago. And she's been having severe infantile atopic dermatitis and cow's milk protein allergy too. This was at around, identified at around, I think, 7 or 8 months of age. But then I mean, they haven't identified it, so they've had repeated episodes of hives and vomitings. I believe a couple of, I mean, 3 or 4 episodes. But this is definitely IgE mediated because it always happened within the first half an hour. So the child has been avoiding dairy since age 1. And she also has moderate persistent, I mean, moderate severe, but I would say a little less than severe persistent allergic rhinitis. It's mostly controlled on intranasal corticosteroids. So the current status is atopic dermatitis, which is very poorly controlled despite good skincare and several flare-ups needing potent topical steroids. In fact, the dermatologist was also considering cyclosporin in this child, and it significantly impacts the quality of life in this child. So, I did a skin prick test. There is a good positive and a negative control, and the DERF was significantly positive even with pseudopods and also the DERP. And she's sensitized to Blumia alternaria, and definitely cow's milk too is strongly positive. So, with this results, so I considered AIT in this child. Basically, it is justified by allergic rhinitis because she has strong sensitization. But I was hoping that there is a possible benefit for her severe atopic dermatitis too, because she's strongly positive or sensitized to house dust mite. And of course, CMPA avoidance has to be done. So this should be done under close monitoring, and I would evaluate for her the response to rhinitis and atopic dermatitis. So coming to a very important one again, this is the venom for the venom allergy. This is one area where it's an absolute indication to start immunotherapy. If it's a severe anaphylaxis to Hymenoptera venom envenomation, then this is the only absolute indication. So basically, after systemic reaction, and SCIT is the route of choice. And unlike for aeroallergens, it's not usually 3 to 5 years, it's for several years after that as well. And this is the final case here. So this is basically a 42-year-old man with onset of asthma at 25 years of age, which was basically like infrequent exacerbations on budesonide formoterol SOS only. But then he's also had seasonal allergic rhinoconjunctivitis, mostly in the months of February, March, and August, September. He's been treated with intranasal corticosteroids, olapatadine eye drops, and he needed several rounds of corticosteroid eye drops for his flare-up of allergic conjunctivitis. So 5 years ago, he has some blurry vision. He went to an ophthalmologist, and it was diagnosed with central serous retinopathy. So then this is basically a side effect of corticosteroids. So stopped all corticosteroids. So for the past 5 years, he's only on daily antihistamines and SOS salbutamol, because even the SOS budesonide formoterol, which he was using earlier, is not being given anymore. So it was just on SOS salbutamol. So when he came to me at this point, I've done an allergy testing with good positive and negative controls. The Parthenium, Xanthium, Resinus communis, Amaranthus spinosus, all of this was strongly positive, and house dust mite was negative. So this is a basically house dust mite negative, wheat positive allergy, right? So I've started him on Parthenium, Resinus, and Amaranthus, because there is cross reactivity between Parthenium and Xanthium. So I just chose Parthenium here for his immunotherapy, and symptoms significantly improved, especially the ocular symptoms. So what are the clinical gateway for AIT in this man? So we know that it's seasonal allergic rhinoconjunctivitis, and then it's strongly correlated with the airborne pollen of Parthenium resinus amaranthus, with the peak pollen season in Telangana. And he had this steroid related ocular complication, which is an absolute indication to avoid corticosteroids. So we focused on seasonal wheat pollen for his allergen immunotherapy, and he was very convinced to start long-term therapy. The patient was very much motivated, and we have done it for 2.5 years with a very good response. And so quickly, the barriers to AIT, as we all know, the cost and the access to it, and the patient adherence and education. So a need for a shared decision making. So we just have to be very practical, and then we'll have to sensitize them in the first initial visits, and then tell them why it's so beneficial, how it would prevent neosensitization, and it would modify the course of the disease. So quickly, there is a slide here. It's a comparative guidelines between the Quadri-I, Yaki, and the WHO. So uniformly, all these allergy bodies would recommend AIT for allergic rhinitis and venom allergy. But as I've mentioned earlier, there is some difference in asthma and atopic dermatitis. So they did mention that it should be controlled, but European guidelines have been very stringent that it should be only be mild asthma, it should be a very well controlled asthma, and the FEV1 should be more than 70%. And atopic dermatitis indications are also a little different. The American academies have been a little bit more liberal in trying it for atopic dermatitis. But there is again a global consensus on 3-year duration minimum for either skit or slit. And Yaki has specified the availability, the need for standardized high quality allergen extract. And fortunately for us, we do have this standardized sublingual tablets in the recent months. So I would say the key takeaways from this would be, so AIT is the only disease modifying therapy, but it is still very much underused. But for the success of this, careful patient selection is very, very important, and guidelines from all over the world would support its use. So I've got references from the Middleton's 9th edition, the Quadri 2023, Yaki updates, and WHO 2023 updates. Yeah. And thank you all for the very patient listening, and very sorry it couldn't come up in the slideshow.
Thank you, Dr. Spuri. That was an excellent presentation. Although your presentation was very visible, so don't worry about the full screen. So, Dr. Neeraj.
Yes, sir.
Yeah, because now is the time for panel discussion, but Dr. Spurti has actually discussed excellent cases, 5-6 cases. So I think we will go directly to the questions. Are you okay with that? Yeah.
Yes, sir. Yes, sir. We can go with the questions.
But this has got very beautiful cases. So I will start with the question from YouTube. There is how far is this? The first question will be to Dr. Spurti. How far is sublingual immunotherapy effective in allergic conjunctivitis? This is regard to house dust mite allergy and also pollen allergy.
So yeah. So right now there is no indication to use or else I could put it in this way: there is no enough evidence to suggest that house dust mite or pollen immunotherapy would be effective for us only allergic conjunctivitis, but it could very well be used if it is in association with rhinoconjunctivitis. But as I've mentioned in my I think one of my cases here, so this child, of course, it's not an allergic conjunctivitis, it's a vernal keratoconjunctivitis. But since he's already had allergic rhinitis, I've started him on it. So per se, if you say that if it's only allergic conjunctivitis and no allergic rhinitis, then maybe as of now we do not have enough evidence to support the use of AIT in those cases.
Sir, can I add something here?
Yes, please, Dr.
So basically what I understand is Dr. Spurti is absolutely correct that majority of the time it is allergic conjunctivitis which is associated with rhinitis, and which is actually a very good marker for you can say like anticipating the response to allergen immunotherapy. If you understand allergic conjunctivitis a little bit deeper, so allergic conjunctivitis can be, you can say like classified into 3 or 4 categories. So one is, you can say like seasonal allergic conjunctivitis, perennial allergic conjunctivitis, and then VKC and AKC. Among these, seasonal allergic conjunctivitis and perennial allergic conjunctivitis, they are usually IgE mediated. And this seasonal allergic conjunctivitis is usually mainly because of the pollens, and perennial allergic conjunctivitis is usually because of the dust mite, majority of the time. So because these are predominantly mediated by IgE mediated pathway, so if it is either seasonal or perennial allergic conjunctivitis with either pollen or dust mite, then at that particular time, the likelihood chances of improvement with immunotherapy is very high. On the other hand, as she rightly mentioned about VKC, so VKC is basically having a dual mechanism. It is Ig and non-Ig mediated mechanism. So at that particular time, immunotherapy, actually it will work only through the Ig pathway, but the rest of the non-Ig effects will not be improved. So that is why the effects are, you can say like not very well documented. And the same holds true for AKC also. In AKC also, it is Ig and non-Ig combined pathway which is going on. And that is why VKC and AKC are probably, you can say like a debatable type of conditions for allergen immunotherapy. But if it is pure seasonal or perennial, then yes, definitely it should work.
Thank you, Dr. Neeraj. There was one question from Dr. Suman Nag. Suman, do the patient need to have a EpiPen or epinephrine at home when they are taking sleep therapy? Dr. Taha or anybody?
So, can you please repeat this?
The question is whether the patient needs to keep an epinephrine injection or EpiPen at home when they are taking sleep therapy at home.
Yes. PK sir just showed the stats, the latest stats. The incidence of anaphylaxis after slit is too low, but still, so, some these anaphylactic episodes in some billion cases or something like that have happened. So for statisticians or for people who deal with numbers, this might be just very less important, but for the patient it's 100% that time, or for the doctor who has been treating those patients who got this episode, be it as less as possible, this episode is 100% for them. So therefore every patient on allergen immunotherapy should keep an EpiPen at home. Of course, we don't have a pen in India. We have the local jugards which are very cheap, but they work very well. We should always have them, especially while the build-up phase is going on. Later on, after the maintenance dose patient has tolerated, we can take liberties. But till the build-up phase is given, we should always have this EpiPen.
Right. Thank you, Dr. Taha. Dr. Spurti, one question from I said because EpiPen is a bit costly as compared to we don't have any Indian alternatives to EpiMed. So what would you tell the delegates how to keep a adrenaline injection, how to use our local methods to keep EpiPen at home?
Yeah, I think as usual, like Indians are very smart, so we have developed our own ways. Right now, we've developed this adrenaline virus. I mean, we have this adrenaline virus, which are actually very cheap, and so we take the dose that's required, and then we store it in a 1 cc syringe, and then we basically store it in the spectacle cases. And I mean, that has to be changed every month, every 2 to 3 weeks. And this is how we have been doing now. But again, the question is, would the patient or the family be able to give the, intramuscular injection? But then at least if they have it with them, right, and if they're traveling with it, so if there is a healthcare personnel or if the parent is trained in doing it, so he should be able to do it. And that's what is being practiced in India now, because not only expensive, but it's also not readily available, the EpiPen.
Right. Thank you.
Can I add one thing to it, sir?
Yeah, please do.
There are two things to this which we need to take care of, which I have actually experienced in my own clinical experience. These things took a couple of things. One is that the spectacle case, what we prescribe the patient should be colored one. Some patients use a transparent one, and sunlight falls on this adrenaline ampule or either adrenaline this injection, which is already loaded, so it deactivates it. Sunlight is the only factor that deactivates it. It should be kept away from sunlight. Therefore, the spectacle case has not to be transparent. One is that. The other thing, Dr. Spruti rightly pointed out that the question is $1 million question, whether the patient will be able to take it or not. For that, PK sir has taught us, and this is what we practice at our places now. Our patients are very well trained. We give them pillows. We have kept a few pillows there at our office, and we tell them inject this in the pillows. Then tell us how would you inject this. Then they make mistakes, and we correct them. This is the order of the day at our places, and invariably I can tell you with this great deal of confidence that our patients, I would say would not be an exaggeration, 100 out of 100 have used this local jugaad of adrenaline quite well and correctly and with results as well.
That was an important message. So, Dr. Neeraj, any input from you?
So, Dr. Taha, I would like to also add up here one or two things. So, one thing is, both of you, I think I must compliment both of you that you have actually added good points. One or two more things. One is that whenever we are doing with this so-called local jugaad, that means 1 cc syringe, then at that particular time, we need to understand that this epinephrine need to go intramuscularly.
Yes.
So, if we are taking this 26 gauge syringe or probably an insulin syringe, then at that time the needle length is very small, and it could be going intramuscularly for a small child or 1 year or 2-year-old child, but it will not be going intramuscularly for an adult or for an obese. Then at that time it might be going only subcute or probably intradermally, so which is not effective. So we need to really see, and probably we need to advise them to change the needle depending upon the length which we want that it should go in. So this is one point. The other point which is there is that whenever you are advising somebody for EpiPen, then at that time, actually in EpiPen, you are actually going with one bow, and then with one press, the medicine is delivered. That means it is only one press, one prick. Whereas here, there are two things which are happening. One time, the patient is injecting the needle inside, and when the patient is injecting the needle inside, at that time, it is likely that the plunger of the 1 ml syringe likely to move out. So he need to keep the thumb up. And then after injecting, that means he has pierced once, he has experienced pain once. After that, then he has to push the plunger. So in real life, in real sense, actually it becomes difficult that when he has to do the pushing action after experiencing the pain. So as compared to the EpiPen, this jugaad technology is actually, you can say, like a little tricky. Though what I do usually in my practice, that I usually ask the patient or the attendant to inject to the patient in front of me when the patient is not having reaction. So because if you are asking them to inject it in the pillow, then at that time they are not experiencing that pain, and they are unable to, you can say, like, get that feeling that how to, you can say, like, push the plunger after the pain, right? But when I'm asking them to do it at that time, then at that time their fear actually goes away, that okay, we have already done it in the doctor's office, no side effect has happened, nothing has happened, and I can also see that how they are doing and what they are doing. So this is means like my practice which I am doing. But definitely, you both are doing correct things, no doubt about that.
So the 1 ml syringe, sir, this is really good. I mean, every time you come up with something new for us to learn. This 1 ml syringe, the needle of 1 ml syringe is the bigger one. Of course, the needle of insulin syringe is something what will not suffice. 1 ml syringe is the bigger one, it's the same needle as the used in other syringes.
No, so basically, if you are taking the 1 ml syringe, so 1 ml syringe is usually the Dispoman needle, which I use, Dispoman syringe, which I usually ask them to take. So
Yes,
this
sir.
Dispoman syringe needle is detachable. On the other hand, the insulin syringe needle is not detachable. Okay, so this Dispoman syringe needle is usually 26 gauge. This 26 gauge is a very small needle, so it is not sufficient for a bigger child or an adult. Then at that time, you need to ask them to detach it and change it to the pink needle, which is having a bigger length. So and then they need to fill it up, change the needle, keep it ready, and then keep it in the spectacle box.
Yes, absolutely.
Thank you, Dr. Neeraj. That was a very valuable input from you, which I also learned today. So the next question is the parents will ask, how do we store this? Where do we store? Do we need to keep it in the fridge or keep it? Where do we keep the epinephrine injection? Because a child with history of severe anaphylaxis following some food, or they need to carry the injection around. So how do you advise how to store and how to carry them along?
So
The only thing that, yes, please.
just wanted to mention that epinephrine is basically light sensitive. It is not temperature sensitive. So as Dr. Taha rightly mentioned that it has to be the colored spectacle box, dark colored spectacle box. So it has to be prevented from light, and it need not to be stored anywhere else. It has to go along with the patient anywhere, anytime, in the school, in the restaurant, in the office, everywhere, every time. It has to be with the patient, need not to be stored anywhere.
Just as a quick reminder, sir, we see these adrenaline vials in the ER and everywhere, right? And it's not stored in the refrigerator. It's just outside.
Yes,
The
absolutely.
heart.
Absolutely.
Right. Thank you, all the faculties. So the next question is, there's one question from Dr. Gitartha Barua. If the patient gives history of allergy to dust mite, but both allergy skin prick test and IG levels test to dust mite is negative, then what can we start? Can we start immunotherapy?
Of course not. You need to look at the other reasons for the allergy there. Rule out
Right.
other conditions, allergic rhinitis. There can be many others, non-allergic rhinitis.
Right.
Rule out those things. How can we start immunotherapy with history only? When you are, the actual evidence, which is the gold standard is SPT, and then of course, the other investigations which are done on blood. When both of them are negative, we need to look at what we are dealing with. Then only, go ahead with whatever we do.
Right. Dr. Neeraj, Dr. Spurti,
Completely agree with Dr. Taha. Actually, dust mite is not going to come us and tell us that, okay, your symptoms are due to me only. So it is only we feel that these symptoms are matching with the dust mite. But there are so many other allergens which are also having similar features. Dust mite, what are the features? It is indoor, it is perennial, which is the same features in cockroach also. Same features in different fungal allergen sensitization also. So you will not get, you can say, like a different type of manifestation with dust mite or with cockroach or something like that. So you need to definitely have a proof of sensitization, either in the form of skin prick test or specific IG, or in case of local allergic rhinitis, you need to have this what is called as this provocation test positive. So if the provocation test is positive, then you must have a proof. You cannot start somebody on a 3-year, 4-year, 5-year long medicine without any evidence. You cannot start.
Right.
If you have time, sir, I can share a very small incident with you. Do we have time?
Yes, definitely. Please go ahead.
Actually, this is the other way around. What happened in 2018, when we did not have the CRD available, we got a young female who was 19 or something years old. She had a history of allergic rhinitis from last 8 months or so. Then we tested, obviously, did skin prick test. There was a big dust mite wheal. Then we tried to find, look at the history. History was just 8 months, 6 to 8 months old. At the age of 19, 68 months old, history only, not that typical dust mite, that early morning, not started from childhood, all that. Something looked to be wrong, something needed to be found out. Out of that curious, the second history we tried to take, nothing much came up. it was not, the wheels were big. We had even pseudopodia for DF and DP as well. DF, DP, and Blumia, all the three, sir. In fact, Blumia was bigger. What happened, sir? Finally, what we did was, taking the history, we told the patient to come the next day, because next day her mother was lined up for the same testing. Next day, her mother whispered into my assistant's ear that, you were yesterday taking history of this girl, a detailed history. The one thing she kept away, she concealed, was that she from 1 year has got a pet turtle. And she was trying to find out if that pet turtle had to do something with that allergy. Obviously, out of curiosity, I immediately Googled, did everything whatever turtle had to do with allergies. Nothing much was there, to my disappointment. But at the same time, we kept our cool. We tried. I asked this lady that, what does the turtle feed on? They said there is some food which we buy from the market. And she got the food next day with the label. The label was that contains seafood. It was a fish food actually, which contained shrimps, shreds of shrimps, and the other prawn and other things. It was the cross reactivity actually. She would deal with that food. From 1 year, she had the turtle. From 8 months, there was allergic rhinitis. Had come up. Dust mite was positive. It was actually the cross reactivity which had come positive. So we somehow convinced this girl to do away with the turtle. In fact, she had concealed this thing from us one day before, because she didn't want to do away with the turtle. She thought they might tell me this might have to do something with the turtle, and that's why she didn't give the history of it. It was her mother only who disclosed this to us. And once she, was convinced that she has to do away with the turtle, and when she did it, by next 6 months, she was absolutely free of allergies. Nowadays, it's very easy to do this CRD and find it out with this cross reactivity. So this can happen. I mean, this is where history, as sir just said, takes place. And this got published a case report in 2021. I can share this case report with you.
Thank you, Dr. Taha. That was an interesting episode. So next question, Dr. Spurti, this is a statement that you have already addressed in your case scenario. So, but I will just to reinforce the message. There's a question by Dr. Abhinaya. What is the minimum age limit above which we can start initiate immunotherapy? So just to reinforce the message.
Yeah, yes, sir. It's 5 and above actually. But then if it is, but then it can also be done on a case-by-case basis if it is less than 5, as young as 3.5, or I would say 4 years. If the patient is able to, you think the patient is smart and he would be able to tell if there are any systemic symptoms, it could be done early, because we've already emphasized the need to start at a very early age, even before the remodeling sets in. But as of now, the bodies would say 5 and above, but the latest update from Yaki would say even less than that, but definitely not infants and toddlers.
Yeah, that's an important message. Anything from the other panelists? Any inputs, Dr. Neeraj?
I think I agree with you. And basically, like any of the therapy, when it starts, or any of the, I will say that research, when it starts, it usually starts in the adult. Then gradually, when the efficacy is proven, it shifts towards the adolescent. Then it shifts towards, you can say, like 5 and then under 5. So the same story is there with the allergen immunotherapy. Like for an example, the standardized tablet dust mite immunotherapy, which is available to us now. So it has been approved in India 12 years onward, right? 12 years onward for rhinitis, and 18-year onwards for allergic asthma. But does it mean that you can't give it for 10 years? No, it doesn't mean that way, right? What it says is that whatsoever studies are available till now, so they are telling us that 12-year onward it is recommended. But it is not meaning that less than 12 you cannot use. So same way, more than 5 years it is recommended, but less than 5, obviously, with the allergist consultation, not for everyone. Not for everyone. So with the allergist consultation, case-to-case basis, you can definitely take a call.
I'm sure Nirisar has given it to the youngest people in the whole country.
So I'm giving after means like 3 years or so, 3 years plus. I'm giving it like 3 years plus, because I understand that usually the perennial allergens, they usually manifest somewhere by 2 years or so. The children when present to us, they are almost like 2 years plus, 2 to 3 years of age. So we usually manage the symptoms, which takes some time. Then we convince the parents for a long-term therapy and all those. So by around 3 years, I'm actually starting with the immunotherapy and getting actually very good results, excellent results. No side effects I have witnessed till now with any single patient.
Thank you, Dr. Neeraj. There's another question from Dr. Rajiv Singh. What are the prerequisites of starting therapy? I think they about allergy immunotherapy. What prerequisite of starting immunotherapy apart from controlled asthma?
Asking from,
I
you're
think
asking from,
he's asking about indications.
no, you're asking from whom?
Yeah, Dr. Rajiv Singh, what are the prerequisites of starting immunotherapy apart from controlled asthma? I think suitable candidates where we can start immunotherapy.
So if I would like to answer it like an allergist, so the answer will be that wherever we feel that there is a IgE mediated allergic sensitization which is happening and which is affecting the quality of life of the sufferer, that is important. That means if suppose somebody who is suffering from a mild condition, intermittent condition, no need. But usually people with mild condition or intermittent condition do not go to a physician, do not go to allergy specialist. So usually the people go to an allergy specialist or refer to an allergy specialist only when their quality of life is having an effect. That means at least moderate to severe or persistent condition. So anyone who is actually presenting to an allergist, getting a IgE mediated sensitization positive, matching with the history, then should be started and should be started early.
Yeah. Thank you, Dr. Neeraj. There's one other question. How do we monitor effectiveness of immunotherapy in a patient based on the clinical symptoms only or skin prick tests? Any guideline?
Well,
How-
he's talking about the biomarkers of monitoring the response to immunotherapy. Is it that?
Yeah, I think he means after we have started immunotherapy, after maybe 1 or 2 years, how do we monitor the progress or the how do we
Yeah.
continue the immunotherapy? How do we-
Actually, even now, there are no specific biomarkers in the blood which can tell us, or even on the skin, which can tell us how well immunotherapy is going. It's the two things what matter ultimately: symptom score and the medication score. If symptoms are coming down, you do the scoring. There are five, the 2-3 ways of scoring it. We can share those charts with the doctor who's asking this. One, the other is a medication score. If medication score is coming down, symptom score is coming down, that's the best indicator as of now to tell us what's the response. There are some research tools going on presently, by some biomarkers in the blood, specific IgE divided by total IgE. If that score is coming down, do it after 6 months. If that score has started coming down compared to the previous level, that again is an indicator. But as of now, it's still in research. I mean, no different conclusions to it, but some papers are in favor of it. But as I said, as I know of, with my knowledge in the literature, symptom score, medication score is the two things.
Very rightly said. Any comments from Dr. Neeraj and Dr. Spurti?
I completely agree. Means like for masses, it is the clinical scoring and the clinical symptoms, medication use. Completely agree. Completely agree.
I agree as well.
Right. Dr. Spurti, there's a question from Dr. Gitartha again. If a patient is positive to all the three dust mites, there is DP, DF, and Blomia, he's asking, should we mix all the three or take only DP and DF as Blomia standard stacks are not easily available?
So it again depends upon the immunotherapy that you're using. Right now, the standardized immunotherapy that is available has got only the DF and the DP. It's the same around the world. Even if you look at the sublingual tablets, it's only for the DF and DP. But then if you have the sublingual drops, right, then we can use all DF, DP, and Lumia together. But the other question is, should I do one as a tablet as a this one and Blumia? Probably not. But then we've also have been practicing using the sublingual, the so-called standardized ones with the Blumia, which is non-standardized. Even that's been a practice. So it's a little tricky. It again depends upon how much are you sensitized to DFDP and Blumia. And we've also seen that even if they're sensitized to all three, and if you use only for DFDP, but still it's proven to be very effective.
Right. There's another question. How effective is the oral liquid slit therapy versus the recently available tablet slit?
So
Remind him of the
here I
sublingual.
would like to answer in like 2-3 steps. So the first thing is about the standardization. So we understand that the standardized preparation right now available to us is only the tablet. The liquid preparations which are available to us right now are non-standardized. Non-standardized doesn't mean that they are not effective. They are definitely the drugs. There are no doubt about that. It is something like I'd always give an example of for an example, a famous biscuit like a Parle G biscuit. So a Parle G biscuit you are taking either from Jammu Kashmir or from Delhi or from Bangalore or anywhere, you will always find same, always the same taste, always the same size, always everything same, right? So this is something like a standardization. On the other hand, if you are just taking a local bakery biscuit, which has been made locally, then at that particular time, there could be batch to batch variability. But both are biscuits, both are having good contents, both are good taste, and both are actually, you can say, like sufficing your need, right? So this is the difference between standardization and non-standardization. So for now, tablets, we are having standardized. Drop, we are not having standardized. So this is one difference. Second thing is that the tablet, you know exactly that what you are giving. In drops, you do not know because the drop size could be small, it could be large, right? Two. The third problem, which is you can say like with the tablet, now I will say with the tablet is that whenever you are giving tablet, then tablet is actually getting stuck to one particular place for few seconds, 2, 3, 4 seconds or so. Whereas the drop, it is immediately getting spreaded to, you can say, like a larger surface area. So it is getting better absorbed or faster absorbed. So I cannot say, suppose if you are giving an example that both are available to us in a standardized manner, let's take an example like that, then at that time, which is good and which is bad. So each is having their own advantages and disadvantages. So I think we need to really understand case to case basis that which particular case we can take and how we should take. So rather than thinking about that, okay, drops versus tablet, another problem is about economical issue. For an example, right now, the tablet which is available to us is not that much economical, which you can actually use for masses. It is, you cannot actually use for, you can say like less than 12-year-old. But if suppose I am starting somebody at 3-year, 4-year, 5-year, what should I do? I am having only an option of drops only. I do not have an option of tablet. So both are good at their own places with their own merits and demerits.
Thank you, Dr. Neeraj. Any comments from the other speakers? Take on this.
Yes, sir, I would agree to that. So if someone is affordable, then as Neeraj has said, it's better to go for the standardized ones. But again, in our country, the issue is with the cost. So we'll have to go by the case by case, on a case by case basis.
Right.
The other forms of this immunotherapy in country have been, they have stood the test of time, both the dust mite as well as pollen immunotherapy. And standardization, Neeraj sir gave a wonderful example today. Thank you, sir. This I can use anywhere tomorrow. That's a beautiful example. All have worked. In fact, we have a publication on sublingual immunotherapy, impact factor of 8.5. This publication we have, the immunotherapy we used was the non-standardized sublingual tablets. Most of our 90%, more than 90% of the patients, of our patients of that chunk had used that immunotherapy, and that had worked very well. That got published in Frontiers 8.5 impact factor. So I believe that, if affordability is there, use standardized. If affordability is not there, don't deprive the patient of whatever is available in the country, which is time tested.
Can I ask one question? I have one question in my doubt, means like in my mind. So the question is that I understand that there is some difference, some cross sensitization, some difference between dermatophagoids versus blumia. But my question is that testing a patient to dermatophagoids mixture, that means derpy and derf mixture, versus testing a patient separately, derpy separately, derf separately. So which one you would like to prescribe? That means like ultimately the treatment is same. You do not have a tablet separate for derpy or separate for derf. So the tablet is same. So what is the point in testing derpy separately, derf separately? I mean, it's like I just want to ask this one question. I never test them separately. I test them combined. So that's why I'm asking.
So because I think now we have an option, if it is for the non-standardized one, to mix derf and derpy separately. So in a very rare case, like I would say a handful of them, sometimes the derf could be a bigger reaction than the derpy. then we could always ask them to put a little bit more of the DERF or vice versa. That's the only thing that I would look into. But again, coming to the tablets that we use, it's in 50-50% proportion, the standardized tablets. So in that case, as you said, we can just go for the combined house dust mite, this one. But again, if you're using that kind of an immunotherapy where they mix DERF and DERP, then it might be helpful in a few patients where they have a predominance of one over the other.
I would go with Neeraj Saj over here. In any case, doing it with a mix is better, is easier and better and convenient as well. Because ultimately, there's 80 to 90% of cross-reactivity between DER-F and DER-P immunotherapy as well. So, testing with a mix would be prudent and wise.
So yes, basically, like this was my point of view. Is basically it is the group antigen. So group 1 antigen and group 2 antigen. So group 1 is basically DERF1 and DERP1, and group 2 antigen DERF2 and DERP2. So there is a very high degree of cross activity between group 1 and group 2 antigen, whether it is DERF1 or DERP1. So that is why on the same basis, actually, I am not testing them separately. And because I do not have a separate modality to treat, I do not have a separate avoidance measures to give to the patient. So that is why I'm not testing them separately. I'm just giving, you can say, like combination testing and combination therapy. Yes, Blumia, because I am practicing at least in Delhi, and here I am not getting the patients from the, you can say, like the Blumia area, this thing. So I am not testing with Blumia, but I agree that if the patient is from coastal area and also, then at that time Blumia becomes an important issue and it needs to be tested. I agree with you.
I think I've asked the same question, sir, in one of the international allergy forums. What they mentioned was right now it's also done sometimes on a research basis, meaning only after doing it for several patients on different occasions throughout the world, we might come to know like how we have component resolved at this point of time, which was not there earlier. So at some point of time, we might come to know that there are more components to each of it, like if you do it separately. So that they said was because it's available and why not? But then again, if looking at the cost effectiveness, then I would just do the together.
Yeah, so I think Dr. Spurti has brought a very important point and a futuristic point. So as we are now having component result diagnostic, which is a in vitro test. So in another, I think another 2 or 3 years, we are going to have, so now I know the companies, so the companies are right now working, and we are going to have component skin prick test also. So like DERP1, DERF1, DERP2, DERF2, or DERP10, skin prick test solutions will also be available in the form of components separately. So the companies are right now working on that, and they should be available in the 3 years down the line or so.
Yes, so in the recent EARCI, I think it was in UK or something, they had one of the companies has put up that already on display. They are doing this component resolved, component-based skin testing. They had put the antigens as well.
Yes, absolutely.
Somebody told me, somebody who had gone there.
Absolutely. Yeah.
I think I will take the one last question. There's a question regarding whether can we start immunotherapy if patient is sensitized only to minor antigens. I don't know what they mean. Dr. Abhay means by minor antigens. Maybe.
Probably if they've done the component resolve, sir. I think probably when a component resolve was done, that's what I just get. So maybe the DERP1, the DERP2, or the DF1, and that DERF and that DERF1 and 2 is negative, but probably the DERP10 or DERP23 was positive. I'm just assuming that's the question. So again, it's difficult to establish that the standardized one, we do have the DERP1, DERP2, DERF1, DERF2 in equal proportion. We know how much is it, but definitely there is also those minor components which have not been standardized or established, but it definitely contains it. So I think they will be benefited even if the minor component is positive. But again, it has to be done on a case-by-case basis and the severity of the symptoms.
And supplement it with an SPT as well.
Yes.
Because,
So, as per the recent EARCI guideline, means like there are flow charts in which they have given the flow charts as per the components. And in that component, they have seen that if suppose somebody who has tested positive, let's take an example, 2 patients, both patients have tested positive for DERP23. Let's take an example. One cohort of patient has tested positive either to group 1 or to group 2. That means DERP1 or DERF1 or DERP2 or DERF2. Other group of patient who is negative to group 1 and group 2, but positive to 23. Then at that time in the first group, they would like to start with AIT. In the second group, which is isolated 23 positive, they have said no AIT. That means isolated 23, no AIT. But yes, with this standardized tablet which is available, it is having some component of 23 also. So the answer needs to come up, means like a definite answer needs to actually come up with more studies. But current guideline says that only 23, no AIT. If associated with either group 1 or group 2, yes, AIT. But I think this is not the final answer. It needs to be discussed and evolved more.
There was something more interesting what Dr. Shenedier or somebody who actually presents most of these CRD talks, even Neeraj sir, he was in our first talk of CRD series, that doctor from US. He presented a case recently in Goa. I was there. He presented it online, and he said they had done component testing in a patient who was allergic to peanuts, and they had started with doing a immunocap, a full antigen. I mean, and non-components of antigen that was positive, and later on the components also had come out to be positive. I asked him, why did you do this whole antigen first? If you had to do a CRD, then why did you do CRD straight away rather than doing the whole component for whole immunocap first, FADIA first? Then he gave an interesting answer to this. He said, the names of these epitopes are as per the chronology of discovery. For example, DERP1, this is the first one was discovered, and then DERP2 and blah blah. So he said same about this peanut as well, RH1, 2, 3, 4, 5, 6. He said there are many other epitopes which might be discovered in future, which might be even having a more severe allergenicity, potential of being allergenic and causing anaphylactogenic as well. So sometimes the patient might be negative to RH1, 2, 3, 6, even 8 and 9. But he might be positive to some component which is yet undiscovered epitope. That's why we do the whole antigen first. Even we do the skin testing, just not to miss any of the undiscovered epitopes. So that interesting thing came from him, and none other than the horse's mouth. So
this is actually true. Like in my patients also, I have witnessed this phenomena. Like many times, the patients are coming and then you are testing with a whole wheat extract. That could be either specific IG or the skin prick test, and you might get a negative result. And then when I am doing, you can say like component, and at that time I am getting actually gliadin, omega-5 gliadin positive. So how it is possible? So the explanation is that the whole wheat extract might not be having the representation of all the components equally. And some of the components might be, you can say like present in so minute quantity, then they are not picked up. Or vice versa, it can happen that the component testing itself is missing some other components which might be positive, and you are testing only few selected components only. So definitely that is why whenever you are testing, no testing is foolproof. Component doesn't mean that you have done component, that means nothing else is needed. It's not like that. You need to really understand that what you are going to test. And if you know that what you are testing and you are getting the answer, then it is okay. So component testing, all test results negative, doesn't mean that the patient is not sensitized to any of these as a whole allergen. It is still possible, very well possible, definitely possible. Very well point taken. And means like we are actually looking these patients. We are seeing these patients. Yes.
So I think we had an excellent discussion. Dr. Neeraj, would you like to take one or two more questions, or do you need?
I think, sir. This was like a really fantastic panel discussion and fantastic session, which has been moderated by you very efficiently, very effortlessly. And I think the first session by Dr. P.K. Vedantan sir means like he always means like he's always, you can say, like considered as the apex or the pinnacle of allergy. And he brings each and every time something different, something new. I must have heard him at least hundreds of times, but each and every time I found him something different, something new, something more interesting. So he's always at his best, followed by Dr. Taha. I think he has definitely, you can say, like connected all the dots and all the rewiring and the dewiring he has done very beautifully, telling us that how this allergen immunotherapy is acting, and you can say like efficiently acting, and why there is a need and how it is acting. And then I think everything has been put in context by Dr. Spurti so beautifully, typically the case presentation, which I really like. With all these case presentations, different scenarios, different testing positive or negative. And then she told that how to proceed further. So which was actually, that means like from books to the clinical side. So everything happened in today's webinar. So I think we have done with the first webinar, and this has actually set the tone for the second webinar, in which we are actually going to discuss more and more about skin prick testing, specific IG, component testing, and then thereafter how we can actually predict the efficacy or the other parts of the allergen immunotherapy, and discussing about more about skit and slit. So I must request every one of you, every one of our listeners, to please attend us, please join us on 4th August, 8 p.m. for the second webinar of the series. 4th August is Monday, 8 p.m., second webinar. Till then, thank you very much and goodbye. Good night. Thank you.
Thank you, sir. Good night.
Thank you.
Dr.
Thank you,
Spoolia
sir.
and Dr.
Thank you,
Pahar.
Mridul sir, for the excellent moderation, and thank you, Neeraj sir
Thank
and
you.
Pahar sir.